Good morning, everybody. We'll go ahead and get started with UW Cardiology Grand Rounds. It's my pleasure today to present Hailu Tilahun, one of our graduating cardiology fellows. And so Hailu did his undergraduate degree at Occidental College, his MD and a master's degree in epidemiology at Harvard, and his internal medicine training at Beth Israel Deaconess before coming out west to join us here in Seattle. He has a long-standing interest in global health and cardiovascular health in sub-Saharan Africa in particular. He has done clinical work as well as research in several locations. He's done this in Addis Ababa as well as in Botswana. It's a real pleasure to hear from him this morning on the topic of acute coronary syndrome in sub-Saharan Africa, current state, challenges, and opportunities. Hailu, take it away.
All right, thanks, Greg, for that introduction. Good morning, everyone. I'm going to be, talking to you about something I'm very passionate about. Global health, something I've done for a few years now, and then more recently in cardiology. With the talk titled ACS in Sub-Saharan Africa. And I hope will be a pretty interesting conversation. So the objectives are really, one is to understand kind of what's the current spectrum in terms of the prevalence of the different types of ACS. What are the management strategies in Sub-Saharan Africa. And then some of the challenges that these places and resource-limited settings face with ACS management, and then talk about kind of what are some approaches to improving, ACS outcome. I have no disclosures. And to give you an outline of kind of more specifically what I'll be talking about, first is, what's the burden of ACS? And I want you to kind of right now think about what you think is the burden. Is it a top priority and issue, or is it somewhere in the middle? And then talk about ACS risk factors. Is it different from kind of what we see in Western countries? Is it something unique, or is it similar to kind of what we see here? And then get a sense for that current ACS management using some examples. I'll talk about kind of the ACS project that I did in Ethiopia with Dr. Roth's mentorship. Some of you might know that I'm originally also from Ethiopia. And then look at some cases, Kenya, East Africa, Ivory Coast, and West Africa, and South Africa, and to get a sense for that. And after that, obviously, talking about those cases, we'll cover some of the challenges. There are many, but some of them I'll highlight those. And then based on that, and just talk about what are the potential approaches to address these gaps, and what maybe you and I even can do as part of that. So starting out, what's the burden of ischemic heart disease or ACS in sub-Saharan Africa? And this is something that a lot of people, when I talk to people, they think maybe it's not as much as this. This is based on the 2017 Global Burden of Disease study. So two things. One is that it's the #1 cause of age standardized mortality for both sexes. This is based on the latest one, 2017. And then another thing you see is it actually has been increasing over time too, and it's actually even predicted to increase further. So I want to dispel the notion that it's mainly communicable diseases that are an issue in sub-Saharan Africa, but not kind of non-communicable diseases, including cardiovascular disease. That's really not the case. These places actually face what's called kind of the double burden of disease, both communicable diseases like HIV and then communicable disease like ischemic heart disease. Next part is in terms of kind of the risk factors. There's again this obviously this is still an ongoing conversation, but are the risk factors just completely different? And there have been several studies. I'm just going to talk to you about this study. It's called the InterHeart study. This international case control study looking at basically trying to get a sense for what's the main risk factors for, in general, ACS? And in this case, they're looking at first-time acute MIs, and obviously case-controlled studies. So comparing it to people who don't have it, trying to see what's the population attributable risk, which means basically how much of the outcome, in this case, acute MI, can be explained by a set of exposures or risk factors. So here what we're seeing is, if you include smoking history, current or former diabetes, hypertension, dyslipidemia, here they use ApoB and ApoA1 ratio. It's actually something that's used. It basically reflects the non-HDL, because that's what the ApoB is found in, LDL, VLDL, intermediate density lipoprotein, to ApoA1, which is HDL. So you can think of it that way. They used it here because they said it wasn't going to be affected by fasting status. And then the last thing being kind of waist height ratio, kind of trying to get a sense for abdominal obesity. So if you look at just even these 5 things, in this study, it accounts for about 90% of the population attributable risk. What essentially it's saying is, and we'll see this further, the traditional risk factors actually account for a lot of the MI and ACS we see. Of course, there might be some other unique things that can add, but the problems we have here are also problems there. And if you have traveled abroad, you will see that there's a lot of smoking, there's a lot of diabetes, hypertension, and if you have worked abroad, that's something that comes out right away. I want to show you kind of what the US outcomes are, just so a reference. So when we talk about the case in Ethiopia, Kenya, and these other countries, so there's a place to kind of start from. So this is based on the AHA's heart disease and stroke statistics. I've just kind of put it in the tables to make it easier. This is the most recent update, and it's based on data from 2018. And in terms of the breakdown, it's something I'll be mentioning a lot for the other countries, estimating, maybe about 30% STEMIs, and then the rest on STEMI unstable angina. This is relevant because obviously the management is different between these 2 entities, and the resource needs are very different. So that is always important. I think, the thing that comes out from the table is, in terms of medical therapy, there's pretty high uptake, in the upper 90s for a lot of things. In terms of that, for STEMIs, PCI within 90 minutes, that, 96%, I would say pretty good timing in terms of that. For the thrombolytic agents, it comes down to 56. In my mind, that's also connected to the kind of place that's using thrombolytic agents and doesn't have PCI capacity, is probably the kind of area, even in the US, where it's difficult, the resource might be limited in terms of distance, things like that, and that might be why not meeting that 30-minute recommended goal. In terms of outcomes, you see that STEMI, at least in hospital, mortality was about 6% and about 3% for NSTEMIs, and keep these things kind of in mind as we talk about other cases. I have here the European kind of STEMI latest guidelines from 2017, essentially the same as ACCHA, I think it was from 2013. I put the European because in my experience, these countries tend to use the European guidelines, but basically the main thing to highlight here is that reperfusion therapy, in terms of class 1 indication, is indicated if someone is presenting within 12 hours from symptoms onset. And, this is used in a lot of these studies and in a lot of these countries as, to determine eligibility. Obviously, after that, if there are ongoing symptoms and things like that, it can be considered, as you can see, 2A, 12, 48 hours, just in general. Of course, if someone has ongoing symptoms, we all know primary PCI strategies, what's recommended. If that's not an option, then, thrombolytics or fibrinolysis therapy. But that 12-hour is key in how people are treated in a lot of these countries. So I want to talk to you first about this project that we did in Ethiopia. Like I said, I'm originally from Ethiopia. That's where I grew up before coming here for college. This is, and it was done at Disparity University, Black Lion Hospital. It's the main, essentially, teaching hospital. It's the main public hospital. It's a referral center. And I had worked there as a resident just for clinical rotation as an internal medicine resident. So I knew people from that, and Dr. Roth had some contacts there. So that's kind of how we got connected. They had interest in collaborating too. If you have worked abroad, it's the typical public hospital in sub-Saharan Africa. It's crazy, it's chaotic. The waiting room is hundreds of people, as you can see. It's a massive place. Interestingly, had a cath lab built, I think, support of Norwegians about a couple of years ago. Not necessarily fully functional, even though it's there. There are a few cardiologists there who most in the past used to get their training from essentially, going to India, Korea, some people in Europe. As of 4 years ago, they have a general cardiology fellowship that stopped at some point, but kind of on and off. And there's a CCU that has 4 beds, and that's kind of the setup. For about a year and a half, they were using kind of electronic system just for recording discharge diagnosis, and that's kind of what I used. And beyond that, it was good old-fashioned studies and just charts, biopsy, and that's essentially what I did as my research project for a month as a second year, and just kind of entering that data. This was more a pilot study to get a sense for kind of the state of ACS there. And actually, this work was we presented at the Washington ACC, and later on through kind of the national ACC, was presented virtually as a poster presentation with the local collaborator, Dr. Dejuma Ideda and Dr. Roth. So just kind of going through some of the findings in terms of the age distribution, nothing too remarkable, kind of maybe what you expect, almost, 60% in that 40 to 60 years of age group. I think the first thing, that catches your eye is barely any women who are admitted with the ACS, as you can see, 9%. We'll talk more about this, why that might be, and what we see in the case of other countries. Similar to what I mentioned with the intra-heart study, a very high prevalence of these quote-unquote traditional risk factors, hypertension, almost 2/3, the 40% diabetes, hypertension, 1/3, lots of smoking too. In terms of kind of the breakdown, basically almost 60% of STEMI, so that means that a lot of need for somewhat urgent treatment and approach in this setting. In terms of when looking at some of the outcomes, a lot of people are actually, or essentially everyone, this is actually, I have to say, it's a small study, 67 people, but everyone got, antiplatelet therapy and anticoagulation. So that was pretty impressive, or there's a pretty good uptake of that. When it comes to, reperfusion therapy for STEMIs, only 18% were eligible, at least using that 12-hour window. And because, a lot of people presented late, and within that, from that 18%, even only 12.5% actually got thrombolytic use, because people actually had to pay out of pocket. There was no thrombolytic in the hospital, and so they have to buy it from a private pharmacy. And interestingly, even though there was a cath lab, I was very surprised by this. And they do PCI in an urgent fashion. They were not doing PCI for STEMI, which sounds, counterintuitive, but because of operative, I guess, not enough experience, or not discomfort, let's say, maybe more with even the peri-procedural management, essentially they're not doing PCI for STEMI. So as a result of that, no one got in this time frame, which essentially was over kind of in between March 2017, November 2018, about a year and a half. No one got PCI. And looking at outcome, mortality, maybe it's because it's also a small data set, but 7.5%. And lots of, this is in hospital diagnosis of heart failure, 40% having that. And that's maybe not too surprising because of, essentially most people were not revascularized. So I wanted to talk to you now about the case in Kenya, another East African country, maybe similar economic status, slightly better off compared to Ethiopia. More private hospitals or at least there's some private hospitals that are fairly good in Kenya. And this study was done at the Aga Khan Hospital. It's one of the private hospitals there. It's a private teaching hospital that has a cath lab. It does have a cath lab, and they do PCIs, and we'll talk about kind of, is it always working kind of things. But basically, about, in this case, 44% STEMI, about 56% NSTEMI. What we see in this table is the same kind of theme again, mainly men, over 80% for both, so very few women. A lot of the same kind of traditional risk factors in terms of diabetes, hypertension, smoking, and dyslipidemia. These numbers, the total cholesterol, HDL, LDL, you multiply by 39 to convert into what we're used to. Essentially, there is dyslipidemia as the point there. And there's also kind of obesity or overweight, abdominal obesity too. The authors show here time of onset or from symptom to presentation. Again, in this case, about 42%, at least in the STEMI group, presented after 12 hours. And that's kind of what you see in this table. For their case, for at least in this private hospital in Kenya, teaching hospital, they didn't specifically say it, but based on numbers, it seems like everyone who was eligible did get some sort of reperfusion. About 70% got thrombolytics and 30% PCI. Didn't get into exactly why not everyone got PCI, but based on kind of reading between the lines, the availability of like on-call the PCI capability wasn't always there, and kind of reflective of those numbers. Looking at the outcome, pretty high, mortality rate of almost 15% for STEMI, and then and STEMI much lower, but still 2.3%, and significant heart failure in hospital, heart failure diagnosis, about 40% in the STEMI group and 16% in the NSTEMI group. And talking about another case here at the, Ivory Coast, Cote d'Ivoire, that's West Africa. And put it in a table. The data was a little bit all over the place. This one was a prospective study that was done over a 3-year window, 2010, 2013, at the essentially main heart center in Abidjan. That's one of the big cities. 425 patients, as you can see, mostly in this case were STEMIs, about 70%, and STEMIs, 30%. Same thing. A lot of the risk factors are there. A pretty good, uptake of at least, aspirin therapy, anticoagulation, statins. In the case here, about essentially 29, about 30% are admitted within 12 hours. So 70% were presented more than 12 hours after symptom onset, so limiting their eligibility for reperfusion. And as a result of that, of the total STEMI patients, about only 15% got reperfusion therapy. Again, a combination of PCI and thrombolytics. So about 50%, about 50-50 was what wasn't the case. And in terms of the outcome here, as you can see, 11% in hospital mortality for STEMI and almost 7%. So high numbers. I think we saw 2 point something, 1 point something in the case of the US earlier. And lastly, in terms of the different countries we're looking at, South Africa. South Africa is a very interesting place. It's in some ways it's very advanced. It almost is a middle-income country, but there's a tremendous disparity, unfortunately, also around racial lines. So it's a mix of a lot of things. This study, it's part of the ACS study. It's a multinational study, and this is the South Africa part. And actually was done in 29 sites and included, total 615 patients with about 60% in STEMIs in the end and 40% STEMIs. Kind of the same things that we saw in the other countries. By this point, you're saying, okay, we get it. But, high prevalence of these high diabetes, hypertension, dyslipidemia, smoking, and obesity. As you can see the numbers there. A lot more people are able to get angiography. In the case here, more than 90%. And a combination of thrombolytics, PCI, and CABG. In this case, 85% of patients presented within that 12 hours. So a lot more people are eligible. Based on kind of how the study was done, they did 30-day outcome. That's just how it was designed. So much lower compared to the other ones of 2.4 and 1.7 30-day mortality. So I have talked to you about kind of now the different countries and some of the spectrum, how it's managed, the outcome. And one thing, I think you have gotten a sense for, and I've repeated several times, is one of the challenges is delayed presentation. And so I've made just a table kind of summarizing what I've been mentioning. And these are just shocking numbers, at least in the case of Ethiopia and Ivory Coast, 80%, 70% presenting more than 12 hours and impacting their management. And even in Kenya, 40%. South Africa is probably the one that has the best data around that. So obviously the question is why? So think about how do patients get to our facilities in the US, wherever you work, or for the most part, and that's mainly through emergency medical services. So the question I had is like, okay, what's the case of EMS in sub-Saharan Africa? And this is a very fascinating, great study that was done a few years ago, looking at based on surveys and contacting the main essentially experts in each country. Only 16 countries at that point had an EMS system. I mean, that's again, it's a little bit shocking, maybe not surprising, based on kind of the data you see. So then you start thinking, okay, how many people then have access to EMS? And this is kind of part of the same study. So in sub-Saharan Africa, only 10% of the population is within what's covered by EMS area. And I mean, that number tells you everything you need to know about the state of kind of at least ACS care. And obviously, even outside of just the medical part of the management ACS pre-hospital, there's of course transportation issue too. And even in the places that EMS, when they did the analysis further, only a quarter had a 25, like a public toll-free number they can call. So it means otherwise they're calling a private company, which, based on how people live there and their income is just not realistic at all. So this is a big challenge. Another thing is, there are other issues like if they go to a facility, health post, do they even recognize it? So there's also that issue. But another thing I want to kind of mention to you is the issue around symptom awareness. And this has been actually looked at well. I'm going to show you just one example, one study out of northern Tanzania. This is a Duke site. Some of you might be familiar with it, Moshi. So they looked at an urban area, rural Moshi, and basically saying, just asking people, what do you think are the symptoms of a heart attack? And they used, culturally appropriate, I guess, descriptions of a heart attack. I know in the case of Ethiopia, there's actually no word for a heart attack, which makes the whole thing difficult. So you have to describe it. So a lot of people say they just don't know anything. And just to give you an idea, this was basically the majority have finished primary school. Some have finished secondary school, and very, maybe 6, 7, 8% have finished college. So that's the, the kind of community members that were being interviewed. But still, basically more than half did not know anything. Only, people say chest pain or shortness of breath, if you even add it up, assuming they're separate, probably not, is, about 7, 8%. And the thing that was reported the most is maybe not specific for the ACS. So like feeling worried and sad. So I think it shows a big gap here, because obviously in a place like like the Ethiopia example, we had 67 patients in a year and a half of a place that's a referral place, a major hospital. So it means most people are not even making it to the hospital, period. So that a big part of that is lack of symptom awareness. And another thing that came out from looking at the case in Ethiopia and just looking at the other studies for me is the reperfusion therapy availability. So just kind of, again, I put in this table. And so even for patients who are eligible for reperfusion therapy, either thrombolytics or PCI, these are the numbers of who got it. And the case of Ethiopia and Ivory Coast is fairly low. I mean, obviously the Ethiopia one is a more shocking, of 13%, but even Ivory Coast, only about half get it. And the cases, at least in Kenya and South Africa, they were able, like everyone was able to get it, which was pretty, impressive. They're also teaching hospitals, but more private and maybe a little bit more well off. There were still gaps in the case of Kenya. This is more a quality issue for that hospital, but it is another significant challenge, even if you make it through symptom awareness, getting to the hospital, but not being able to get reperfusion. And to highlight this, I'll give you the example of Ethiopia, based on the Human Development report, just the latest one. About a quarter of the population lives what's now below the poverty line. It's about $2 a day. And at that point, when I was doing this research, you would have to, it's actually the oldest form of streptokinase, and you have to get it from a private pharmacy for $30. Again, the number tells you everything. So if people are below a quarter, less than $2 a day, unlikely people can afford $30. And then the other issue there is, even, it's a big deal for a place like that to have a cath lab, and to even have it, but then to not have the operator maybe training, the nursing training, the CCU, even though there's a physical CCU capacity and training, to not do stenting for STEMI kind of shows you gaps of, I don't want to say maybe training, but it just needs more support. So it just kind of shows you the challenges. That's not just about putting, the machine itself in a room, which actually in itself was a big challenge, but it extends beyond that. Another thing, maybe, I have mentioned and caught your eye is this gender disparity. And just putting it together in this table, again, another, to me, shocking statistics of basically very, very few women, presenting, or at least admitted, let's say, with ACS, because that's how the data is reflected. Fairly low numbers, 10 to 20%, essentially. Automatically, there's some problem. You can say, oh, is it that men have more ACS and things like that? But you already know it's not at the level of 10 to 20%. And kind of further back this up, I want to show you this. This is again from the Global Burden of Disease study, the latest one, and it's showing again the age standardized mortality, or number one cause for females is ischemic heart disease. Again, kind of this is maybe a myth buster, which we kind of know, but it is actually ACS and ischemic heart disease is a major issue for women, and it's a major issue for women in sub-Saharan Africa. Obviously, this is aggregated for, it's a large region, but it gives you an idea. It's not 8th, it's not 10th, it's not below that. So then, you have to think, why is that? The issue of, it's just maybe women present differently, and that's the case. Maybe it's being under-recognized. I would challenge you a little bit on that. There's the GRACE study. It was done in European countries in South America, almost 20, it's based on the registry, like 27,000 people, and with men and women who presented with ACS, and comparing their symptoms. And interestingly, actually, the number one presenting symptom for both were actually chest pain, 92, 93%. And that wasn't different. It was true that women presented more with kind of jaw pain and nausea, in which, at least in the study, was more statistically significant. But I wouldn't think that, that in itself, that small difference is going to account for, a difference of 90, like only 10% women in Ethiopia presenting, or 20% in the other countries. But, obviously that's something, the other presentations of chest pain, I wouldn't even call it atypical. It's just a symptom presentation in different subpopulations. There is, in these different studies, an idea, at least in sub-Saharan Africa, that, heart attacks are like a male disease, a men's condition. And it's not, so that there is a lack of awareness in the whole community and among women. So that's another thing that came out from these different studies. Again, other things, obviously unequal access to care. Who has access to care is always a question. And that's something, the same thing. Women don't have as much agency and power in a lot of these countries, and they might have a lot of actually tasks and duties at home that prevents them from showing up to these healthcare facilities in general. So that, just the last part is, so then what, what can we, or what are the things that can be done? And it's obviously, it's going to be based on what are the major challenges. I think, maybe something that's more the easiest, but it's key is because I've told you about how there's a very significant lack of awareness of ACS symptoms, and if you're not aware of heart attack symptoms, you're not going to do much, or maybe by the time you try to do something, someone has collapsed and it's too late. So this was a great study looking at basically trying to get a sense for how do people even get their information about CVDs in these different countries, and it's across many countries in Africa. And basically, it's not to go through the table, but the idea is obvious. Before you do anything, you have to know like how people are getting even their information. Because if it's mainly through like the social groups, and that was my experience growing up in Ethiopia, is obviously there's a lot of close community functions, weekly things. So that's how people got a lot of their information. And you are spending your time through the school curriculum, that might not be the most effective way, especially if people are not even finishing, high school or things like that. So you have to understand that part, and then in a way that's relevant to the local system, then, try to kind of increase the awareness around the symptoms. And obviously packaged as part of the whole overall health education. The other, huge thing is around I'll call it just in general, pre-hospital care. It actually has been shown, there's been costing analysis, which is not surprising, that if you invest in pre-hospital care, you're going to save money in the long run, or actually even in the medium run. Because you're not just doing it for cardiac, it's for all trauma and all these emergencies. And maybe the graph didn't, or the figure didn't project well, but what it's showing is, areas with coverage of electricity and then a mobile phone. So if you've been to sub-Saharan Africa, if you've worked there, one thing you would notice, and that might surprise you, is even places that are super remote, not a whole lot available, people have cell phones. So these places, basically less than 10% electricity, but a decent number have cell phones. So that's maybe one thing, using like cell phone based management for pre-hospital care, and using some of the local things. You can find taxis in most parts of sub-Saharan Africa. They might not be always fancy, but at least that can be part of the transportation part. Obviously, you have to work out the legal part of how that can be done if there are complications. But instead of waiting just for fully equipped ambulances to be in place, that's something maybe that can be explored. And this paper also looked at how just having different levels of response too. Community member checking on someone, of course, with the goal being a trained professional, transporting patients. But while that's being worked out in this resource limited setting, and then the treatment availability part, I would say actually that more comes with advocacy. Because it's on the WHO's essential medicines list. At least the thrombolytics and the main cardiac medications. So I think it's more on the Minister of Health institutions to have that, and obviously there might be some need of work with pharmaceutical companies to address that issue. Then the last thing, I'm going to mention here before finishing up is global partnerships. And this is where you and I come in, being in the US-based, providers, cardiologists, there's a lot of interest out there. Obviously, the one way to do it is through an academic medical center. As some of you might know, I'll be actually starting at Virginia Mason in July. And that's something I'll hope, or actually plan to do, is to have these partnerships with the site in sub-Saharan Africa. And I think all of us can be a part of this, because as you can see, the need is tremendous, whether it's the cath lab and supporting people who work there, or around nursing in the CCUs, or whatever it might be. And there are already some partnerships. That's something that can be developed more. So in conclusion, I want to mention that, and have it in your mind, that ACS and ischemic heart disease is an issue. Not only is it an issue, it's the #1 cause of age, standardized mortality. Some of the key challenges, there are multiple, but around issues around ACS symptoms and poor pre-hospital care, and then even once you get there, kind of the issue around reperfusion therapy. And then the last thing is just kind of what I mentioned, but there are great opportunities, if you're an academic medical center and you want to do research along with the clinical aspect, it's something that can be done, or even even within private cardiology or as an individual, it's something that you can take part in and make a huge difference in people's lives, which kind of the main reason that a lot of us are in this medicine, essentially. So that's